Thanks again. I'll try and keep this extra quick because everyone's done really well, like learning a lot in the last sessions. But like now, take a big breath because you're going to have everyone's favorite topic, multi-drug resistant gram-negative infections. So yes, acknowledging country again, you can tell I wasn't sure which of my talks was going to be first today. So look, I'm excited to talk to you about this topic because it is a genuinely new topic and in some ways a new type of topic in the antibiotic guidelines. The content was developed by a subgroup of largely dual-trained clinical microbiologists and ID physicians. And it has a slightly different target audience from the usual TG topic, which is intended to be very broad, very entry-level, safe sort of advice for someone who may not have a lot of experience in antibiotic prescribing or infectious diseases. This topic, I think, will be useful for people in that scenario, but also for junior doctors who are working in the infectious diseases space. I think it's actually valuable for everyone, so I would encourage people after this to not only, if they're working in infectious diseases or microbiology, read this topic themselves, but talk about it with any people you supervise working in that space. If you're looking for it, in the table of contents, it comes initially under Candida and resistant infections and then multi-drug resistant gram-negative bacteria, but you can also search for it with a number of key words. And the scope of this was recognising here in Australia and indeed around the world, we're seeing increased complexity and increased numbers of multi-drug resistant gram-negative bacterial infections. So this topic includes a general overview to the topic, as well as a brief discussion of the concept of intrinsic versus acquired resistance and what that means in general for infection control, just to help people avoid that confusion, whether just because I have a infection with a Pseudomonas aeruginosa that's resistant to ceftriaxone, does that mean I need to isolate the patient? Well, no. The topic also has the approach that there needs to be different action to manage patients, potentially depending on whether or not they have an actual suspected or confirmed multi-drug resistant gram-negative bacterium versus they're unlikely to have that, and also if they're severely unwell. So that's whether or not you have time to wait on standard therapy or if you need to go to this alternative therapy or get advice on that up front. And patient factors that clinicians should consider that may influence the antibiotic choice. So a checklist of the most useful patient information. And that can facilitate a discussion by someone reading this and then interviewing the patient and then discussing with ID and microbiology. So I think Ed has already shown this, and this is one of the figures in the table. So this helps you decide, is the patient in front of me more likely to have an infection with a multi-drug resistant gram-negative bacterium. So it includes all the usual things as well as some explanatory text around that. But there's another figure that also is helpful if you need to determine, well, if this person does have an MDR, gram-negative bacterial infection, what additional factors might help the ID micro person predict to which drugs it's likely to be susceptible and help decide on empiric therapy. For example, whether or not they've had an infection with a particular MDR gram-negative infection recently, or if they've been overseas to a particular place where a certain type is endemic. So it's going to help with that decision making. And then, yes, almost finally, this took quite a lot of work and quite a lot of discussion. And so I hope it's presented in a way that is useful to people. But we actually wanted to help guide people with thinking about treatment choice for infection with multi-drug resistant Enterobacterales in particular. So this table here provides advice on antimicrobials that are likely or less likely to have activity against certain types of CPE, CRE with threefold categorisation. So based on mechanistic data and Australian susceptibility data, those that are likely to have activity in the column on the left, those that may or may not have activity in the middle column, and those that are not going to or are unlikely to have activity. And then on the column on the far left, the resistance mechanism of the most common types of carbapenem resistant Enterobacterales enzymes, so the beta-lactamases. So, and including things like the IMP and NDMs that we see in Australia more commonly than things like KPCs and VIMs, which are often found in international guidelines where those things are more common. So the table's intended not to be a definitive recommendation for therapy, but to be used in conjunction with expert advice from a clinical microbiologist or expert ID physician, and may help with requesting testing. As I said, it's informed by mechanisms as well as local susceptibility data. But also there's some text below this table in the topic that includes a bit of advice on ESBL bacteria, for which recommendations are generally available in the individual topics elsewhere in the guidelines, as well as a discussion on AMP-C producing organisms and how to approach empiric therapy with those. So, take-home messages. There's a lot of new content in this little chapter to assist with the management of MDR gram-negative infection. It's really pitched at an ID registrar or perhaps an interested JMO or other medical officer level. There's advice in there that will help with history taking and transference of clinical information, information on potentially suitable options by the likely enzyme type, and as I said, latterly, some additional information on management of AMP-C producers and ESBL producer infections. Thanks.